If not, I'd like to invite my co-instructor, Dr. Amrita MOHANTY, to talk about Microsporidia.
Good morning, everyone. I shall be talking about a very interesting organism that is Microsporidia, which is a small obligate spore-forming intracellular parasite that infect a broad range of vertebrate and invertebrates. It was first described as an interesting parasite as European silkworm disease. Later, in 1973, the first case of microsporidial stromal keratitis was described by Aston. It infects multiple organs, most commonly the GI tract, followed by ocular infections, then respiratory, muscle, kidney, and CNS. So in ocular manifestation, it is most commonly manifest as epithelial keratoconjunctivitis, followed by stromal, rarely endophthalmitis, and scleritis. It occurs worldwide, but has a wider prevalence of 0 to 50%, most commonly in the South and Southeast Asian countries. Sorry. The route of infection is fecal-oral, whereas the source of ocular infection is not clear, mostly following exposure to the dirty water of ponds, swimming pools, or among rugby players, then followed by contact lens users. Rarely in cases of refractive surgery, it has also been reported. Previously, it was reported to be in an immunocompromised patient, but now there is an emerging ocular infection among immunocompetent patients as well. So regarding the organism, it belonged to the phylum Microspora and kingdom Protista, but now is recalcified as a sister fungi because of molecular and morphological similarities. It has more than 1,300 species belonging to 200 genera, of which 7 are most commonly reported in the ocular infection. Encapsulizone cuniculi and hilum has been reported in the keratoconjunctivitis, whereas the vitiform cornea, previously known as Nosemia corneum, has been reported in the stromal keratitis. It has two phases. First is infective stage, which is outside the host, and the multiplicative or the sporogony phase occurs inside the host. So coming to the clinical presentation of MSK, which is quite interesting because it ranges from suppurative inflammation, as you can see in the top two picture, where you can see multifocal, deep-seated stromal infiltrate with or without an epithelial defect and hypopyon. The second middle two picture, you can see there is a monofocal, deep-seated infiltrate, usually associated with an epithelial defect or sometimes perforation and hypopyon as well. And the below two pictures are very interesting, where you can see just a quiescent scar, which might be an active microsporidial keratitis, which causes more confusion and is misdiagnosed as HSP keratitis, and rarely fungal keratitis, and some slow-growing atypical bacterial keratitis. The most interesting part is it doesn't have a definitive clinical management. So when you suspect MSK or microsporidial stromal keratitis, when the patient has a long-standing history with a waxing waning course, usually misdiagnosed and treated as HSP or fungal keratitis, do not respond to the standard medical therapy of antibiotic and antifungal, and interestingly, it is also culture negative. It does not grow in our usual culture plate medias, but requires specific cell culture lines. So when you suspect MSK as a clinical diagnosis, as you can see, it can present as grayish-white, fluffy infiltrate, which can be unifocal, multifocal, and diffuse. Sometimes they do present as pigmented capes, which you can see adjoining to the area of keratitis, associated with perforation, sometimes rarely with vascularization, in contrast to the HSV, and sometimes also as a quiescent scarring with minimal edema. So as it is a deep-seated infiltrate, the microbiological diagnosis can be done by a corneal scraping if it is accessible, or a corneal biopsy by raising a triangular or rectangular flap and scraping in the base as well as the flap of the corneal biopsy flap that is raised. Coming to the stains which are used, Most commonly used is the 10% KOH, potassium hydroxide, and 1% calcoflower white stain, where you see a typical hyperfluorescent oval to round structure which gives a starry sky beautiful appearance, or in the gram stain where you can see the stippled appearance because of the location of the vacuole at the end of the spore. Sometimes germination tubules as this tubular structure can be seen in the gram stain as well. And the modified gel Nansen stain, that is 1% acid fast stain, also you can see this round to oblong spores. Our group has reported that KOH along with KOH calcoflower along with Jaden staining to have a sensitivity of 96.7% followed by gram staining and GEMSA staining. In this picture, you should always keep in mind of the differential of the yeast because they closely resemble, but the size of the spore are small, typically of 2 to 4 micron infecting the humans, and also they are non-budding. Then coming to the molecular diagnosis, our group has reported 16S RNA based pan-microsporidian PCR, which are specific primer set for encephalozoon species, that is Cuniculi, Helem, and intestinalis. It has a sensitivity of 83% and specificity of 98% and can act as an adjunct to the corneal smear examination. Similarly, as discussed by Dr. Garg, confocal microscopy can play a pivotal role when it is a deep-seated infection, and also you can follow the course of the treatment. But the only thing is they are very small and difficult to locate in view of the background noise by the inflammatory cells. But as you can see, these are hyperfluorescent dot-like structure usually occurring in clusters. As discussed, it has high inter-observational variation, availability and cost has to be kept in mind. To have specific identification, TM can be done, where you can see the number of coils which determine the type of species and number of nuclei, and DNA sequencing. Histopathology, this is the HE stain where you can see there is epithelial ulceration and DM is also not intact at few places. And there are numerous spores. This is a magnified picture. You can see the spores along with the inflammatory blue colored are the inflammatory cells which are mixed PMN and lymphocytic cells. This is the Jaden staining where you can see these spores along with the inflammatory cells. So why the management of MSK is difficult? Because it is a chronic long-standing disease with a duration of presentation ranging from months to years. So it acts by evading the host immune response. It resides in the keratinocyte for an extended period. Delay in diagnosis can occur because of this non-specific clinical feature, culture negativity, and most commonly misdiagnosed with HSV or fungus, and its initial response to the topical steroid. And also at the last, we do not have any definitive medical treatment, TPK being preferred till now. So although in vitro experiments have found a wide range of susceptibility for this organism, but it does not match with the clinical response. Combination of 0.02% PHMB or chlorhexidine along with oral albendazole has been tried. As you can see in this patient with moderate MSK being recovered in 6 weeks of this therapy. Similarly, there has been several case reports of using topical voriconazole along with oral itraconazole or albendazole. So this is a case series of 5. This is A to F is the initial presentation of 6 size 5 patient where we have treated this with a novel therapy, that is topical fumigaline. The percentage is a little bit lower, that is 0.007%, along with voriconazole and oral albendazole, where we have achieved clinical response with a median of around 9 months of therapy and with no recurrence followed up to a year. Surgical management, as I have said, is the preferred management till now, has been reported to have a success rate of 73 to 95% with repeated therapeutic PK as reported by our group and others. So this 4th picture are very interesting because it will be very interesting to know what has happened to this patient. So the first patient is a case of HSV endothelitis where you can see footprint scars, vessels, previous history and treated with oral acyclovir and topical steroid. B and C are suppurative inflammation where the diagnosis was achieved by corneal biopsy and ended up in therapeutic PK. And the fourth one has a moderate like MSK case where we have managed the patient with topical fumigaline and diagnosed by confocal microscopy. So this is an interesting case where the patient has been treated with us for 2 years as HSV keratitis with oral acyclovir and steroid, and it came with a suppurative inflammation where the smear examination revealed microsporidial spores. DALC was done because it was just involving the anterior two-thirds of the stroma, but the patient ended up with multiple graft recurrences, ultimately ended with a large TPK. So therapeutic PK is still now the preferred treatment for this kind of cases. So coming to the microsporidial keratoconjunctivitis, which is very different to that what we have been discussing about the MSK. This is very superficial epithelial keratitis where you can see this multiple coarse raised SPKs round to oval in region with or without fluorescent staining. Most common differential diagnosis for this MKC is adenovirus. Bilateral involvement has been reported in 8 to 32% of cases. Average duration of exposure to dirty water to that of onset is around 2 weeks and mostly reported in tropical regions during the monsoon season. Low et al. Have described according to the location as central, peripheral, diffuse SPKs. Our group have again described a ring-like SPK pattern. Keratic precipitates, typically non-pigmented, following the resolution of the SPKs, that is around 1 to 2 weeks of appearance of the SPK, can be noted. Coming to the differential of the MKC, adenovirus keratoconjunctivitis usually unilateral or bilaterally asymmetric. There are multiple punctate lesion. This is the subepithelial infiltrate you usually see following the adenovirus keratoconjunctivitis, and they leave behind subepithelial scar. And treatment is usually by topical steroid and tacrolimus. Whereas thiogation SPKs are usually occurs in young and middle-aged, are bilateral as asymmetric. They are coarse, slightly raised subepithelial lesions with variable staining, with chronic exacerbation and remission, and respond to topical steroids without any residual scarring. Other clinical presentation of MKC can be limbitis, corneal edema or endothelitis, and nummular keratitis, which require topical immunosuppressants. So, regarding the treatment, epithelial debridement along with oral albendazole or itraconazole and topical broad-spectrum antibiotic like fluoroquinolones and antiparasitic medications have been reported in the literature, but our group has showed no difference between the topical BHMB and the lubricants, as well as no difference with the epithelial debridement. And we prefer topical lubricants and symptomatic treatment for this patient. So this is the treatment algorithm published by our group. So MKC does not require microbiological examination always, but in case of any doubt you can do a simple smear examination to detect the microsporidial spores. So usually they respond to the lubricant and clear in 2 weeks. If they develop any scar or persisting SPKs or subepithelial infiltrate, can be treated with a short course of topical immunosuppressant, that is steroid and tacrolimus. And uveitis usually resolves on its own, but in some recalcitrant cases or when the AC cells is more than 1+, you can always give a trial of topical steroid, but after resolution of the active SPKs. Similarly, severe conjunctival congestion, chemosis or limbitis can be also treated with topical steroids. So this is an interesting case where a 26-year male who was previously treated with epithelial keratitis with us came after 2 months with this kind of very atypical ring-shaped stromal lesions with edema and surrounding subepithelial lesion. This is the AIOS2025 which shows the corneal edema and subepithelial scar. This is the other eye which has peripheral subepithelial scars. Interestingly, on scraping it revealed few microsporidial spores in the gram stain as well as in the KOH. We did a real-time PCR for adenovirus and pan-microsporidia. PCR was positive and negative for RT-PCR HSP1. So we treated it with broad-spectrum antibiotic because of the epithelial defect we made and topical steroid. So this is the 1 week visit where you can see the edema has significantly reduced and the topical steroid was tapered. This is the subsequent 4 week and 8 weeks visit, and it had no recurrence for the 1 year follow-up. So mixed infection with adenovirus has been reported previously by our group, having an incidence of 17%, around 17% along with the microsporidia. Then we came up with this series of 20 cases where you can see the interstitial keratitis like picture with disciform or multiple nummular scars or ring form, which completely resolves with topical steroid, which had rapid resolution with it, and the adenovirus was detected in 70% of cases. Thank you. I'm happy to take any questions.
Thank you very much, Amrita. If there are any questions.
Thank you. Thank
Hello,
you.
sir.
Tacrolimus for viral keratitis, how long do you use it and how often? Please.
I'll like to qualify, it's not viral keratitis that we are using. We are using it for nummular. And many times these patients require tacrolimus for almost a year or so, because it has a waxing and waning course. Oops. Just twice a day.
Yeah, just on that point, many of these organisms become, the infection settles, but the immune response picks up. And the immune response then keeps the disease progress. So you're treating that with either cyclosporin or tacrolimus or even steroids. But steroids have a chance of reactivating the infection, which cyclosporin and tacrolimus is less. I just want to make, you emphasize this point. I think we did this study on corneal vascularization, and we found that the commonest cause is herpetic eye disease. So whenever you see any scar, active lesion or chronic lesion which is not vascularized, it's unlikely to be herpetic.
That's right.
And the interesting point we also noted was that the commonest cause for lipid keratopathy is vascularization produced by herpetic disease. So even the vessels are not the same. The vessels from a bacterial infection or from trauma or for virus are different, and most lipid keratopathy comes from virus-induced vessels.
Yeah. Thank you for that interesting point.
So, yeah, fumagillin is available in our pharmacy. You can order it, and the percentage that we have used is 0.007%. We have formulated in our pharmacy, but previous reported was a little bit higher percentage of around 2 to 3 milligram per ml. The advantage of using this relatively lower percentage of fumagillin is the stability, but you need to keep it in the refrigerator. So what we do is we give 4 bottles of fumagillin to the patient. One is to be kept at the room temperature, the rest 3 need to be kept in the refrigerator. And they can eventually use it for 3 to 4 weeks. The stability has already been published by like other authors regarding this.
The main thing that you have to keep in mind with the fumagillin is that the average duration of treatment is 9 months.
Right.
It's not going to show you response quickly, and therefore these patients become very nervous over a period of time. What is happening?
And also we have given oral albendazole after our physician clearance, and also our LFT and CBC has to be repeated in every 3 months. So basically, medical management can be tried in mild to moderate cases only, with anterior to mid-stromal infiltrate with minimal AC involvement. Wherever we see frank suppurative inflammation or deep-seated infiltrate or perforation, we prefer therapeutic PK.
No, but it's still, Minashri, it is the main line of treatment for microsporidial stromal
TPK.
keratitis, even at our center, continues to be full
Surgical.
thickness penetrating keratoplasty. So these are cases which have been enrolled for a specific study, and we found that possibly patients who are not willing to undergo therapeutic keratoplasty or those which are small off the visual axis, you can give a medical, a trial with the medical treatment. Okay, thank you.